we realized that we were really coming together in a public health effort.
We tried to keep the lines of communication open even during the darkest of times.
My thinking had always been triage, forecasting, and being able to ensure that every patient could be seen and treated.
I learned very early on that the only thing you can count on is change, and that resources will never last forever.
When it comes to cardiovascular care on the organizational level, MedAxiom understands the challenges your program is facing. Welcome to MedAxiom HeartTalk, the podcast where thought leaders come together for one ultimate goal: to continually transform cardiovascular care for all. MedAxiom HeartTalk starts now.
I'm Melanie Lawson, a journalist in Jacksonville, Florida, and host of MedAxiom HeartTalk. Today's episode is within our Structural Heart Innovation Series. We are talking about the PEARLS paper. It's those pearls or best practices that might be just what you and your CV team need during these challenging times. As COVID-19 has magnified the systemic issues in healthcare, such as racial disparities and gender inequity, today's guests are among a team of distinguished authors who released a 2021 paper on how to optimize care and structural heart programs in the face of these obstacles. And we are so honored that we have this panel of guests today. Getting everyone together is always a challenge, but this has been fun and we are ready to go. First joining us is Dr. Elizabeth Perpetua, founder of Empath Health Services and faculty at University of Washington in Seattle. She led the efforts and development of the PEARLS paper and the first published study describing the structural heart coordinator role and coordination in the U.S. Dr. Kimberly Guibone is Structural Heart Clinical Program Manager at Beth Israel Deaconess Medical Center in Boston. She brings extensive experience as a doctor of nursing practice and the first valve coordinator of her structural heart program. Next up, Martina Kelly Speight is the lead nurse practitioner for the transcatheter valve therapies program at Stanford Hospital. She was the original coordinator for all of the landmark structural heart clinical trials and has been with her program for more than 15 years. And last but certainly not least, we have Joan Michaels, Director of Cardiac Registries for the American College of Cardiology in DC. She brings more than 30 years of experience in cardiology as a registered nurse and expertise overseeing the STS ACC TVT registry. All right, so we could probably spend the entire podcast introducing our guests because they have such extensive experience and bring so much to this table. So we do encourage you to read everyone's full bios in the episode notes. But first, let's welcome to the podcast these ladies, Dr. Elizabeth Perpetua, Dr. Kim Guibone, Martina Kelly Speight, and Joan Michaels. Thank you all so much for joining us.
Good morning, Melanie.
Happy to be here.
All right. So the first question, if you've ever heard Heart Talk that we ask all guests is, why did you decide to get into healthcare? It really gives us kind of a dive into you a little bit. Did you ever have that aha moment, or what was it in your family that made you go into this field? Dr. Perpetua, let's start with you.
Sure. Thank you for the question. Well, my mother is a nurse. Almost all the women in my family are nurses, and everybody's really in healthcare. And service, really being there for one another and having science with the heart of what we do was something that I was raised with and ultimately chose as my career. And I still love it to this very day. The aha moment was my father had a heart attack when he was 38 years old. So I was very young. I was not even 5. And I remember it so clearly, and it just really stuck with me. I wanted to be sure that there would always be some way for there to be options and a way for patients and families to understand what was going on.
Yeah, I hear that story so often, somebody directly touched by someone who has heart disease or had a heart attack, and it just has catapulted them into their greatness, really. Martina, what about you? Your aha moment?
Yeah, like Dr. Perpetua, I'm also the daughter of a nurse and also, from a family very much rooted in sort of civil service. So Nursing was, of course, encouraged, but at the same time, it was something that I very smoothly gravitated towards. And I honestly feel that it's very much my vocation. And I do feel that way. And with that, I can't imagine doing anything else. And just it's brought me tremendous opportunity and honestly a great amount of fulfillment. So for me, it was just a very natural pathway.
Perfect. Dr. Guibone, what about you?
Well, very similar to the first two. I grew up in a small town in New Hampshire where I landed. I too was destined for healthcare as the daughter of a nurse and a physician. And when I think about topics like we're going to discuss today, I recall my father was trained in the Philippines, came to finish his work here in the U.S. And then we as a family went back to the Philippines because he had a goal to try to reach out and provide medical care to the more remote areas and villages in the jungle, if you will. We left there due to political unrest, and that's what brought me to New Hampshire. And most unfortunately, my father passed away when I was in high school. But what I do recall is growing up with very many stories about things like access to medical care and resources, and having to make those difficult decisions of who got treated and who didn't. So along the way, I learned very early on that the only thing you can count on is change, and that resources will never last forever. And it's been a driving force for me in my career in healthcare.
All right, Joan, you're up. Do you have a similar story?
I do, definitely influenced by family, specifically my sister, my one and only sister, who is a nurse. And so I followed her to the same program, and then actually followed her to the same hospital where we worked together, which in hindsight was a beautiful memory and a lot of fun experiences. She's been my guidelight, my mentor throughout many decisions, but definitely with healthcare. Fast forward, as many of the speakers have mentioned, it actually came in very handy to be a nurse as parents grew older and needed to maneuver through the healthcare system. And I feel like I've learned a lot professionally, but also personally in taking care of family members and now friends who are experiencing cardiac issues. And we know we know the back line, we know the way to streamline their care and to give them guidance as they need help. So starting out with following my sister, and it's been a ride of a lifetime and the best job ever. Thanks, Melanie.
I love it. A lot of powerful folks in this room, and I'm sure that there are parents and siblings that are so proud of the work that you're doing. So amazing way to start to understand your stories. So PEARLS stands for Planning, Efficient, and Resource Leveraging Systems. The paper says to mitigate negative impacts in the face of crisis or capacity constraints, this paper offers best practice recommendations to implement optimal care in SH programs. So Dr. Perpetua, can you describe a few of the factors that compelled you and fellow authors to create this PEARLS paper?
Sure. Thank you, Melanie. This paper, we often say, is a career's worth coming, because many of us were there, again, at the front lines, the very beginnings of structural heart. And back then it was the valve itself and the opportunities to treat patients because of the scarcity of the availability of the valve that was actually the rare or the more limited resource, as Dr. Guibone had mentioned. We always wanted every patient to be able to have the opportunity to be seen and treated and have the information that they needed to be able to do that. And we knew that it took processes and people. Now, here we were 10 years plus later amidst a pandemic where we'd had the opportunity to learn from one another, to educate people all over the country. And there was still a need to now, amongst this evolution, have a framework, a schema, a roadmap that people, whether they'd had, their programs for, 10 years or 10 months, could follow and could start to understand in a granular way, not just, I know I have to do these things, but I need to know how to do these things, whatever the limited resource is. And so we started, one of my physician colleagues that we all know very well, Dr. Mark Reisman, and I started working on this paper initially as an editorial, and it wasn't enough. we needed to really create it as best practice recommendations. And even the name itself, Pearls, came out of this group. And we came together with all of our voices, all of our perspectives. Yes, starting with, what was initially an editorial and the experience that, was kind of unique to the Seattle area and that geography, but then expanding it to really become something that could be applicable regardless of the region or what the access or resource need was. So that was really how this authorship came together and how the paper came together.
I love starting as an editorial and then becoming a roadmap. I mean, that's pretty tremendous. And to be able to get everybody involved in that. Dr. Guibone, you're clearly perfectly placed, but how did you get involved in this project? And what are a few of the issues that you were seeing in your program?
Well, I think it is specific to COVID. It did not roll out evenly across the country, though it was just as deadly, just as crippling, just as devastating to every site it touched. There were differences in the readiness and the benefit, although slim, of others' experiences that have gone before you. I think personally that there's the experience of New York City, and then there's everyone else. To have that tsunami of illness at your door, literally the stacking of the body bags, not knowing what you were bringing home to your own family and not knowing what to do next. I can't imagine that. In the Boston area, we were just a couple of weeks behind that. So not as terrifying, but certainly also still a challenge with the patients that we faced. And what we knew was our own patients, they weren't going away. Their diseases weren't stopping in their progression. They remained just as ill, and there were more coming. And so how do we manage this in the setting of having to quickly pivot to remote work with a skeletonized team? Most of the procedural staff was redeployed elsewhere. And then there was the issue of having no beds because of the volume of COVID patients that were coming in. But we knew that we had to keep our patients safe. We knew we had to figure out how many we could defer and who absolutely needed to be treated and how we were going to do that. So I did the obvious. I reached out to my friends, my colleagues, my confidants, those who I've worked with throughout all the years in building these programs. What do we do now? And then how can we help the others? How can we prevent some of this from going forward to the following sites? And I think that in the first month of COVID in the US, 2/3 of the cases were concentrated in the New England area. So in many ways, we truly were the canary in the coal mine for the rest of the US.
I'm sorry, you gave me chills going back to those moments. It was just such a terrifying time. I'm so glad that we're kind of out of that time. And now we have a bit more perspective on what to do when, and if we go down that road again. Martina, let me bring you in the conversation. Can you share with us what you were seeing early on and how that informed your perspective on this paper?
Yeah, also, exactly to Dr. Guibone's point, it didn't roll out, everywhere, across the U.S. like we had assumed. And what's unique to us in California and specifically here in the Bay Area is that we were actually one of the first, or probably were the first community to shelter in place and begin those sort of early intervention of stay at home, lockdown, shut down, all of those things that we'll remember forever. And in fact, I don't think I'll ever forget getting on the freeway and driving to work when everybody on the news is saying, stay home, and being so isolated on the highway and driving in and again, not knowing how much COVID was at the hospital and what was I going to encounter and all of that. But what was wonderful was the hospital administration did start communicating that sort of information to us just to help us, allay our fears in terms of what we were going to be encountering on a day-to-day basis and giving us that data about how much COVID we had, or in this case, didn't have. Now, they, of course, like many other hospital centers, bracing for the wave that we thought would come in that first wave, they did shut down elective procedures for most surgeries. And when I think elective, I'm thinking more like orthopedic. But fortunately, they heard us when we said our patients are not here necessarily for elective cases. Yes, they're scheduled cases, but these are patients that have critical valve disease, and we all know the trajectory of their outcome if we ignore and put these patients on the back burner. So fortunately, administration heard us early and really, came together that gave us the opportunity to continue to treat our patients. And fortunately for us, we had the ability and the capacity to do so. And ultimately, getting together with the women here on the call, as we do so often on so many issues, but it was really neat when we started to connect about these issues and these unique experiences that we were having. We realized that we were really coming together in a public health effort, and that we were starting to talk about concepts of triage, capacity, disparities, resources, surveillance, and that not only were these principles being applied to our hospitals, but these principles needed to be applied to our structural heart programs. And that's really how it came together into those beautiful charts that you see in the paper with their labels of red, yellow, and green to help us identify and appreciate the differences that we were experiencing.
Such important research to be done, in a time as that, and to be able to benefit from it long term. Joan, let me bring you in the conversation. You recently said, now more than ever, the TAVR community realizes the value of the valve coordinator. So can you explain a bit more?
Sure, happy to, Melanie. I like to call us, not necessarily the TAVR community, but I've pinned us as hashtag TAVR Nation. And TAVR Nation came together with breakneck speed about what needed to be done, what could be held, what could be done during telemedicine, or perhaps lengthen the time frame that we were allowing the data points, the endpoints to be collected. So everything was still taken care of and the patients were treated in a safe manner, but we were able again to pivot versus what initially crossed over from pre-market to post-market to registry data. I always say the TVT registry is not your grandmother's registry. It's not a procedural, retrospective data collection tool. It's a program, and that program is really drawn and supported by the valve coordinators to do the pre-procedural work. The procedural work is all other registry data collects, but then we also collect follow-up data. So how do you get 30-day and 1-year follow-up data during a pandemic? And they did without skipping a beat. Nothing, we went from in-person meetings to virtual meetings in a month's time, almost like an ongoing support group, if you will, to the valve coordinators who were struggling or who had questions. We tried to keep the lines of communication open even during the darkest of times.
Wow. So Dr. Guibone, I want to bring you in. You were under a lot of pressure. The very first valve coordinator of your structural heart program, everyone's watching and seeing what that means and how that changes the game. You've helped define the role of the valve coordinator over the years, and you've seen the demand for these skills and expertise increase. Can you explain what that's looked like for you and just to see this need explode?
Yes, Molly. To be honest, when I started, I didn't know what it meant. I don't think many of us knew what it meant. But I was fortunate to partner with these colleagues, with these thought leaders on this call, as well as many others, to slowly develop what is actually a very complex role. Initially in the design, the idea was that this might be a person who coordinates, who schedules the testing, who schedules the clinic, who gets the patients from consult to procedure table. But in actuality, it's so very much more than that. You're working with very acutely ill patients with multiple comorbidities who hopefully can walk, but probably not, definitely are having difficulty breathing. And you have to create a system that they can be safely transition from evaluation to procedure. So that means partnering with administration, partnering with all the multidisciplinary specialties in the hospital, a lot of education for the patients. And what we realized early on, as reflected in a paper by Dr. Megan Coilwright and Dr. Michael Mack and colleagues, in which they identified that although many structural heart or TAVR programs recognize the need for a coordinator, very few of them actually incorporated the cost or space or resources for such a role in putting together the cost assessment of the overall program. So what we learned early on with the complexity of patients is you either had to have a high level of clinical expertise or a lot of experience or both. And since that time, the role has grown because now that we actually have these programs underway, how do we make them better? So now as the valve coordinator, how do you improve efficiency? How do you improve outcomes? What kind of quality improvements can you make for continual improvement and reducing length of stay, reducing costs, making the outcomes better and safer for the patients? And then to add an additional layer, the indication for use is now broadening to a younger age population, which is fantastic for access to care, access to options. But that comes with a very different twist. Now you're caring for the patient throughout their lifespan. How do you manage that? And so now the valve program coordinators are very involved in shared decision-making as an advocate for the patient, encouraging the patient to be an advocate for themselves. And so this role continues to change. And what once was thought to be simply a matter of scheduling the patient to get them where they needed to be, now you're actually guiding care and guiding the therapy. And maybe not so much spoke of the heart team in the program, but perhaps the hub.
Mm-hmm. You wonder what it will evolve into eventually. All those things are so necessary. Well, that sounds like a great place to pause for a quick break. You hear the term care transformation a lot, but what does it mean exactly? Care transformation is redefining the way consumers buy and use healthcare by developing new products, treatments, and business models that integrate separate healthcare organizations or activities. MedAxiom understands that moving the needle in CV care is not simple. It takes vision and leadership, and it requires bridging technology, innovation, and care delivery. MedAxiom experts are helping programs across the country shape the future of cardiovascular care delivery. Through education, organizational performance solutions, and advocacy, we are evolving disease management, innovating virtual care, driving the data revolution, and redefining access and team-based care. Let's transform cardiovascular care together. Get started at medaxiom.com/care transformation. Welcome back. So far, we have talked about the catalyst behind the PEARLS paper and the essential role of the valve coordinator. So now let's take a deeper dive into what listeners can expect when they engage with the paper. So the paper describes optimal care as the right care for the right patient in the right place at the right time. Dr. Perpetua, can you walk us through this in a bit more detail? And should we consider the PEARLS paper to be a standalone playbook, or should organizers use this as a way or more of a template to create their own playbook?
Sure. Thank you, Melanie. First off, it is intended to serve as a guide. And like anything, for a guide to be used, it has to have principles or pillars that are meaningful, but that can also be applied to whatever the center or the site's needs are. My experience has been as a nurse practitioner, and then later, working with teams to bring programs together. My thinking had always been triage and then forecasting and being able to ensure that every patient could be seen and treated in a way that reflected their goals and how the organization either had space, staff, supplies, and had standards around that. It was never more complex than it was when we had structural heart, because we had, as it had been said earlier by Dr. Guibone, by Martina, by Joan, we had multiple, clinicians, cardiac surgery, interventional cardiology. We had a number of diagnostic studies. We had very, complex patients that may have multiple comorbid conditions, and they had their own goals. And then how do we bring the people and the processes together to serve them? And, really that triage and forecasting and all of the surveillance that we do is based on what that risk is of the patient, based on how acutely they're presenting, and really based on their goals. If a patient says, hey, I want to be able to go and see, my grandson's high school graduation, and that's coming up in a few months, and I'm, so short of breath that I can't do these things. And now, the pandemic has really caused us to ramp down in terms of how quickly we can see and treat patients, and access is affected. We want to consider the patient and their goals, and whether those goals are aligned with what's actually possible, and have that kind of communication with them and their family so that things are aligned. I think that, really from a how-to perspective, we wanted that in terms of the charts that Martina had mentioned to really reflect what the evidence, was and is, and that will evolve over time too. So in terms of a standalone playbook, it will never stand alone, because there will always be, as Kim mentioned, Dr. Guibone mentioned earlier, the only constant is change, right? Mm-hmm. The framework itself, or the schema, or the roadmap that it offers, will have the same types of principles. So you triage based on, right, their acuity and their risk, knowing their goals. But those items that you're triaging on may change. We may have new evidence that says, oh, this thing puts them at higher risk, or, this item puts them at greater benefit. And those things we'll learn, over time. But it starts with the patient, and it always starts with, the team, the center, the hospital, what they have. So we want to be sure to honor that as we're considering the sites, and to offer a framework that is generally applicable and can be used in a site-specific way.
Yeah, I know that's so important to you, people and patients and how they transform the care. So we'll talk about that in a minute. But I would like to ask Martina first, can you share a story of how you and your care teams have used these guidelines and care pathways to improve outcomes for the patient?
Absolutely. I think a lot of centers really focused maybe on some of their inpatient throughput and how this paper could be applied to those efficiencies, but also importantly, because I function as the primary advanced practice provider and manage the FollowUp clinics. There was also it was important that we focused on also the outpatient management of these patients, and how could we keep staff and patients safe within a clinic environment, and still meet and keep up with the framework, of our TVT requirements, which is largely what grounds us in the way that we organize our clinic, and at the same time not wanting to miss a clinical scenario that warrants hands-on care. That was very important, that I didn't miss that opportunity to lay hands or listen with my stethoscope. So it was really decided that the majority of our, say, 30-day patients required to follow up at their 1-month visit, it was decided that we would see them in person. Obviously, we would screen the risk for COVID exposure, on all sides. But it was important to us that we could make sure that this patient wasn't having a complication given the recency of their procedure. But it made a little bit more sense to us to push visits like a 1-year visit, to a remote scenario, or to be able to provide a video visit or a telephone visit, and then creating protocols around that, and setting up templates and making sure that our video visit templates and our telephone templates captured our TVT requirements. So that was pretty important to us, and that's really what grounded the decision about structuring the outpatient clinic in this environment.
Dr. Guibone, what about you? How did these guidelines improve an outcome? You have a story maybe about a specific patient?
Well, yes, actually, in looking at our program, we made an active effort to implement the principles identified in the Pearls paper. We used them to triage our patient acuity, to identify who truly was urgent and needed to be cared for, and then take into account, as mentioned, their acuity, resources available, and capacity constraints. What we were able to do as an institution was develop a separate pathway for these urgent patients, whereby they came in literally through a separate entrance, apart from everyone else, was guided to the cath lab holding area. Again, many of the elective procedures were ceased, so that area was vacant and unused. We used that to care for the patients pre and post. We optimized the staffing, so minimize the number of staffing, but optimize their roles to where the same folks were caring for the patients before, during the procedure, and after. Patients were recovered in the cath lab holding area and then discharged home the following morning. And we did this for quite some time and took some extra effort in the procedures themselves for some safety measures, such as adding an ultrasound at the end of the case or doing an angiogram to assure there was no vascular injury. And then in looking at discharge, according to an algorithm agreeable to all, including the electrophysiology group, we identified who could go home with telemonitoring as opposed to staying in-house to monitor their rhythms for potential complications. And then we took this group of patients and compared them to what we called the pre-COVID control group. And what we were able to demonstrate was a shortened length of stay, lesser incidence of vascular injury, and a lower rate of pacemaker implantations. So a very positive result. And then under the lead of Dr. Mark Tuttle, we went forward and published this as an opportunity to share this experience for others.
I love that. And as we've always talked about on this podcast, is that data, drives action. And so you can show it, you can actually duplicate it too in other environments. So Joan, let me ask you, how is the TVT registry and its data driving transformation of care?
Sure. Thanks for asking. As Martina mentioned and others as well, data is everything. And the TVT registry is meant to be a real world experience. So we tried to keep current with what is happening in the real world versus a pre-market or a trial or a closely monitored clinical research trial. We're real world. And during COVID and using the template of the paper, I was able to reach out to the folks on the phone and others to ask what's reasonable, what's doable, what's achievable in a real world experience during COVID, or you could fill in the blank for whatever the next pandemic or next hurricane or flood will be. And how do you keep marching through any kind of adversity and still maintain the proper endpoints that we need for safe patient care and good outcomes? And TVT is celebrating its 10-year anniversary this year. 10 years has gone very quickly. And it's been a journey in trying to pivot, be flexible, change as the real world experience is going on. And a lot of the changes that continue to be made in the registry are the result of the valve coordinators, again, telling me, responding to questions as to what's happening, what's feasible, what is providing the same outcome, perhaps with a streamlined approach. So during COVID, we were able to quickly pivot and, as others have mentioned, go to telehealth, accept a different time frame for getting mandatory endpoints completed. Instead of a face-to-face evaluation or a face-to-face 30-day and 1-year follow-up, we pivoted to phone calls via mail, depending on where you were in the country and what was allowable or what was a safe way to see the patients. Early on, the patients didn't want to come into some areas at 30 days because they were concerned. But we were able to allow some of those endpoints to be collected over the phone with phone interviews. And the quality of life is a very significant endpoint that we collect both at 30 days and 1 year. And that conversation and that data could be collected by a conversation on the phone. So when you talk about transformation of care, I would say that's the improvement in the quality of the care and the outcomes of the patients, even with the changes that we've had to weave and bob through COVID, and still collect the data that's necessary to make sure the patient is cared for safely.
There's so much to unpack, but let's kind of look at how the Pearls paper concludes with this, which really kind of sets us up for the future. The rapid diffusion of structural heart innovation into mainstream care and the Herculean efforts to recover from the COVID-19 crisis are poignant reminders that systems alone do not transform care, people do. So Dr. Perpetua, let me ask you, do you feel like this whole people transform care, which is so important, because you all work for the patients, and I feel it in your heart that that's what you do every day, but that sentiment is shared by your peers in the CV community. And do you think this mindset will prevail in a post-COVID world?
Yes. I think that, now more than ever, we understand it and we're more open to understanding it and measuring it better, what people do. Change happens peer to peer. it happens in conversations like these, where we get to understand what is it that you do and how can we work together and what are your goals? And really, even in the pandemic, I had the opportunity to work with about, 10 different hospital systems where with their teams, it was about how can we apply these 5 principles of effective team-based care from the Institute of Medicine, which are really simple, but can often be hard to do, especially under stress or in uncertainty. But we have to lean into them and into one another in our relationships and into this heart team approach that we've invested over 10 years developing and enriching. And those 5 principles are, clear roles, shared goals, mutual trust, effective communication, and measurable processes and outcomes. And to be able to tell these stories and to do it with data and to recognize the value that each of us bring to the table and what those contributions are, that is what transforms care. Because we can have guidelines, we can have anything that looks good on paper, a framework, even this paper, but unless it's lived, and unless we come back to each other and ask, how is it going? And does this still apply as things change, as we know they will? And that really is what will allow this to be more of a legacy document, not just for COVID, but for any type of crisis, any type of need that we may have now or in the future.
Yeah, it does appear that this was overdue. So to have it now, not knowing what's next, this roadmap is very vital. Dr. Perpetua, Dr. Guibone, Martina, and Joan, thank you so much for sharing your time, your stories, and your expertise today on MedAxiom HeartTalk.
Thank you, Melanie.
Thank you.
Thank you, Melanie.
Wonderful.
Thank you.
Thank you so much. Well, that is it for this episode. If you liked it, please tell your colleagues and let them know they can subscribe to MedAxiom HeartTalk on Apple, Google, or wherever they get their podcast. If you would like to send us a note directly or suggest a topic, email us at hearttalk@medaxiom.com. Thanks so much for listening.